Good afternoon to you all. I'm really happy to be here. I would like to thank the organizing committee and the Vesalio people, especially Diane Demet, for giving me the opportunity to be here with you and to share with you our experience, although limited with the NeVa device. So I'm an interventional neuroradiologist at Hospital Clinic in Barcelona, in Catalonia. And during the next slides, I will show you our results with that device. So no disclosures. This is our experience with NeVa. So it all started back in January 2018 when we used the first two-drop zone NeVa. We have performed different workshops in Barcelona with Mark at Hospital Bajrami. So 11 workshops till January 2020, and then it all stopped. We have restarted right now with 4 new workshops in the past weeks. And right now, we continue to use NeVa, especially participating in different Vesalia studies. So we got our first publication with 30 patients treated in 4 different centers back in 2019. And these were the first results that we had. So you can see that 63% of first pass TICI 2B or 3, so not first pass effect. And this is really the paper that changed my way of looking at my results and at the different mechanical thrombectomy devices that we use. So I would like to thank the people from the Nasal Registry and Raul for this paper, because this is what they showed us. They showed us, first of all, the concept of first pass effect. So the single pass or use of the device with a TICI 3 or 2C, that means complete or almost complete revascularization with no use of rescue therapy. And they compared these results with the TICI 3 with any number of passes or with modified first pass effect. That means TICI 2B with the first pass. So with other situations in which we were very happy, and we called that success. And this is what they showed us. I mean, in terms of good clinical outcome, the results of the full Nasal Registry were 42%, which are quite typical numbers. These numbers were quite the same when we achieved a modified TICI 2B with any number of passes, and very similar, a bit higher, 52% in the modified first pass effect. That means TICI 2B in the first pass. But when they achieved the first pass effect, when they achieved the complete revascularization or almost complete, which was only achieved in this cohort in 24% of the cases, they showed us that the good clinical outcome went up to 61%. So it was completely different. And the same happened with mortality. Okay, when we take a look to the mortality in the Nasal Registry, they had a 30%, same number with any modified TICI 2B, same number with modified first pass effect, but completely different when we were talking about the first pass effect. So they were achieving much better results in terms of good clinical outcome and also less mortality whenever they achieved a complete revascularization in the first pass. And this is not only that he showed us with the Nasal Registry, but also some other papers that we have seen recently. They've shown, for example, this meta-analysis of the Chinese group with a total of 9 studies. They showed us that first pass effect is absolutely associated with better outcomes than complete revascularization when we are not talking about the first pass. So NeVa was designed with this idea, with the idea of getting, of course, the first pass success. They designed these different drop zones that you can see here. This is what they say, that it has an optimized radial force. It's very important to note that right now they have different devices that we will see later, not only with 2 drop zones, but also with 3. And it has this closed distal tip at the end in order not to lose fragments of the clot. So this is our initial experience, as I told you, the one that we published. So 4 different institutions, and here you can see the first pass. So 2C or 3, 47%, only in 30 patients, okay? And final recolorization with 2C or 3 is 63%, with an average number of passes of 1.7. What about the patient outcomes? Here you can see the mean NIH at 24 hours was 7. The 90-day MRS was 53%, which is quite good. And in terms of safety, which is something that we're always concerned about with new devices, you can see that there were, in these 31st cases, 0 NeVa-related adverse events and symptomatic intracranial hemorrhage with a 23% of asymptomatic intracranial hemorrhage. In these 30 cases, 80% of the cases were done with distal aspiration, and the remaining, probably our cases, with balloon guide catheter. And NeVa was effective with both strategies. That's very important. And in the 40 cases in which they had the info available, they could see that 70% of the clot incorporation was there into the device basket. So this is one of the first images of the different animal labs that we perform in Vallebrón. And this is our standard thrombectomy technique that I'm gonna show you. So in our institution, balloon guiding catheter is always used if feasible, and that means that 80% of the cases we use a balloon guiding catheter. We have been using NeVa primarily in M1 occlusions, although its added value probably is highest in ICA tip occlusions, and also, as I said before, in MCA, especially when the clot burden is high. In terms of flow control strategy, we use flow arrest, and in 50% of the cases, we use a distal access catheter with a 021 microcatheter that is always withdrawn in order to improve the aspiration, and very important, the partial retrieval into the aspiration catheter when we feel the resistance in order to avoid this shearing or toothpaste effect. So 3 important points, I would say, when we are talking about this device. First, choose the correct NeVa size. This is quite common in every single device, but very important, the positioning, because it's a bit different from what we're used to with other devices, and the retrieving. So here I'm gonna show you some slides so you can understand the different markers that we have. We have a proximal marker, we have a distal guide wire, and we have these different smart drop zone markers depending on the type of retriever that we're using, the 2 or the 3 drop zone NeVa. Very important point here. We've got the occlusion, for example, at M1, we can see here the clot, and this is the way NeVa should be placed. So usually when we are placing different devices, like solitaire, Trevo, or whatever, we try to place the clot just in the middle of the device. In this case, when we use NeVa, this is the difference, okay? We have to have the proximal marker or the first drop zone at the level of the clot. So this could be the ideal position. This is not the ideal position. I think it's very important to know that. It's very important to pay attention. I think that I remember on the first days of retrievers, I used to think that any way you use that, that's going to work. That's not true. That's not true for any device, but especially for this one, so you have to place it properly, and this is the way it should be placed. So they have these 3 different devices. The typical one, which is a 4x22 with 2 drop zones. This is the ideal one for distal M1, M2, or ACA and PCA with these vessel diameters, and we use a 021. Now we've got the 3 drop zones, which is a bit larger and a bit longer. Here, ideal for ICA tip and more proximal MCA occlusions, again with a 021. And finally, the bigger one, the 5.5 by 37, with these 3 drop zones, which is ideal for more proximal carotid occlusions, and the microcatheter recommended is an 027. So again, here you can see in these slides, first of all, you have to visualize perfectly where the clot starts, and then you have to place the NeVa as shown in this slide. So identify the proximal edge, the fluoroscopic location of this point. This will be the reference point for you in order to deploy the NeVa. So we usually go distally with the microcatheter, we go with the NeVa inside, and then we go backwards with the whole system just to place it properly. So here again, we have to know during the retrieval that these little markers, the smart markers, they call them, at the level of the drop zones, we can take a look to the way they behave in order to know if we have the clot in that situations, if we have to release the tension, which is something we do at every single point when we arrive to one of these drop zones, in order to open a little bit more, so it would be kind of the push and fluff technique that Raul described some years ago. Here you can see how the markers may be compressed together, so at this point you may be adjacent to a hard clot. We have to slow down, we have to leave it open properly, as you can see here, and then we have to retrieve the NeVa. Very important as well, Once you deploy the NeVa, you can bring the distal access catheter tip up to the proximal markers, or what we usually call as anchoring with the stent retriever in order to go up with these distal aspiration catheters, and you have to remove the excess tension that you may have and slowly retrieve the NeVa. And once we feel this resistance, we usually take out the whole system. So just 2 cases to show you these markers in real life. This is a typical patient with a proximal occlusion at the M1, 2.25 minutes from onset, good aspects, NIH very high, M1 occlusion. We put on thrombolysis before going to the mechanical thrombectomy procedure. And here you will see the markers, which are clearly seen in this. So here you've got the distal guide wire, and here you have the different smart markers at the level of the drop zone. So here you can see the drop zone markers and the AP view, and in the lateral view, this is the typical approach. So we use an 8 French short sheath. We usually use an 8 French flow gate, a Catalyst 6 as a distal access catheter, TurboTrack 21, and a Synchro 14, and this is a NeVa 4.5 by 29. So here another case with a right MCA. And again, I'm going to show you the different markers. So here we can see the microcatheter going distally and doing the typical run. It was very interesting what Mark said before about doing any runs through the distal access catheter. It's something that we usually don't do, or I prefer not to do because of what he showed us, because of the risk of fragmentation of the thrombus. But whenever we go distally, and I know that there is some controversy regarding the necessity of injecting through the microcatheter, but this is still something that I usually do just in order to check that we have had no perforation with the microcatheter or the microguide wire before opening that vessel. So here you can see the markers. So the distal tip right there, very clearly shown. This is the drop zone, drop zone, drop zone. So this is a 3-drop zone NeVa, and this is the proximal reference. And this is the way it should be placed. Here you can see the stop of the thrombus. So this is the proximal reference. So this could be here or the first drop zone where you can see it, but not more proximal, because then you're gonna lose part of the efficacy of the device. Again, here you can see the same distal tip, the markers, and same in the lateral view. And the final revascularization. So yes, during the last slides, I wanted to show you our results right now. We've got a multicentric registry in Spain that started back in June 2019 with anterior circulation acute ischemic stroke, and we have enrolled 1,900 patients so far. These are the different places that they are including patients in Rossetti. So these are the 62 patients that in which NeVa has been used in this registry. You're going to see that in this analysis, we had only performed 9 cases with NeVa. This is the first pass recanalization rate, globally speaking, in these 62 patients in different institutions, which is a 42% of first pass effect. And these are our results, but again, you have to take into account that we're only talking about 9 cases, so not big numbers, with a first pass effect of 67%, which I would say that it's quite high. What about the final revascularization rate? Because obviously we have to keep in mind that our main goal is to achieve complete revascularization in the first pass, but this is still a good result when we're able to open the vessel completely. Here you can see 71% of final complete revascularization of the whole cohort, so 62 cases. And these are our numbers. Again, I repeat, only 9 cases with an 89% of TK 3 or 2C at the end of the procedure. So when we compare our initial experience in those 30 cases I talked to you about that were published, and we compare with our current experience nowadays with 16 cases performed in my institution, you can see that they compare quite favorably. So TK2C3 in first pass, 56%. We always talk about these numbers, and I would say, I don't know if all of you agree with me, that 50% of first pass effect is something that we should achieve. This is the final recanalization TK2C or 3, so 81%. So much better than what we had before. With this technique, again, 93% of these 16 cases were done with balloon guiding catheter, very important, I think, and 50% of the cases with the combined technique. That means with a distal aspiration catheter plus balloon guiding catheter and the centrifuge. What about the numbers if we compare those numbers globally with other devices that we are using? Here are the numbers. So you have to take once again into account the low number that I'm showing you with NeVa. And here, mainly most of them were M1 occlusions. Here we are comparing with other devices in which some cases they had a terminal ICA occlusion. So just to have an idea of what we're doing, you can see that they compare very well. So this 56% with 43 or 54% in other devices, in other centrifuges, and the final recanalization, again, very good numbers. So just some take-home messages about this device. I think Arsida will show you in the next presentation quite a lot more of cases and in another location of the clot, but I could say that first pass effect is really the real goal, that these NeVa drop zones have been designed to achieve these high rates of first pass effect, that in vivo and in vitro results show its efficacy in all types of clots, and that's very important. And finally, that our experience, although limited, as I've shown you, has achieved excellent results with the approach balloon guiding catheter plus NeVa. And I think that's all. Thank you. Thank you very much.
Hello, everyone. I'm going to speak in the first presentation, NeVa and its features, and everything was explained perfectly. So I'm just going to share our experience with NeVa and just one recorded cases with still NeVa. So we have 131 cases that we use NeVa as the first-line treatment, stent retriever. Cases were done between 2018 October until March 2021, and we used three sizes of NeVa. Our mean age was 59, 55 of them were female patients, NIH on admission was 10. And we had a rapid mismatch ratio, mean 7.44 and 96 milliliters at the volume. We use just TPA in 40% of our cases. And when we look at the occlusion sites, we had 80 patients with M1 occlusion, 38 patients with ICA occlusion, 10 with M2, 2 with ACA, and just 1 patient with basilar artery occlusion. When we see to the first pass, we achieved TK2C3 in 53 of our patients, and final TK2C3 in 86 of our patients. But when we see the goal of TK2B and up and greater, we have a approximate 97% of recanalization rate. And with NeVa, I want to focus on the ICA because we had 38 cases of ICA occlusion, ICA tip usually. And of this patient, 21 patients, approximately 55 of them, were just recanalized with just one pass with NeVa. 17 were TK3 and 4 of them were TK2C patients. So NeVa, to our opinion, is very good at achieving high first pass recanalization rate in ICA tip occlusions. And when we see the first pass and final recanalization, TK2C3 of first pass is 53.4, but final recanalization was achieved in 86.2 of our patients, and TK3 was first pass in 34% and 58% in as a final recanalization, with a 1.8 average number of passes for final recanalization. We didn't see any device-related serious events on our experience. We had 27.4 hemorrhagic transformation, but both subarachnoid hemorrhage and hemorrhagic transformation did not result in symptomatic in this patient. So when we could achieve, because we are still evaluating our patients' modifier ranking score, but in 70 in 67 of our patients. MRS to 1 was 61%, and MRS 0 to 2 was 71% with 7.5 1-month mortality. When we see to the timetable, our patients were onset to door mean 329 minutes, approximately 5 hours, with 46 minutes of door to puncture time and 28 minutes puncture to recanalization time. So this is the patient which we recently did in October 2021. It was in his second hour of onset with an NH of 13. Can you play the diffusion? The patient had a very small diffusion restriction in the right hemisphere. As you can see, millimetric diffusion restriction. But rapids show a very high mismatching volume and ratio with a very preferable Tmax prolongation. Now we can see the procedure. I just aim to show the use of NeVa and the placement of the stent retriever and how can first pass sticky 3 be achieved. We chose NeVa in this patient. It has a mild, maybe moderate carotid stenosis with M1, right M1 occlusion. After we place the microcatheter distally to the M1 occlusion, as you can see right now in the video. After placing the microcatheter and I perform my distal injection, then you can see in a few seconds the stent retriever. Kadar yanlış video olmasın. Now you can see that NeVa is replaced distally to the M1 occlusion, and its markers, we prefer to place them distally to the occlusion in order to achieve a better recanalization. In this patient, we performed our thrombectomy and we let our aspiration catheter going down on the stent retriever. When we finish the thrombectomy, we usually with NeVa, it's very easy to decide because if we have a thrombus, you can feel that the thrombus is engaged in the stent retriever. So if you feel that the thrombus is engaged in the stent retriever and your aspiration catheter does not go distally, you can prefer to take them both outside, and we believe that you can achieve a better recanalization. So this patient was recanalized with sticky 3. You didn't show the last injection, that's why I was waiting. Yes, this is the final recanalization, and the patient improved. This is the 24-hour MRI. Just mild millimetric lesions, and the patient improved with an age of 24, an age of 0 in the 24. So this is what we got out of this patient, and you can see how the thrombus is engaged in the NeVa design. And lastly, I have explained this patient in the morning. It's a 9-day patient, which was thrombectomy of the right hemisphere. I will not explain it again. I just wanted to show that when this patient came to us and had a history of late onset, we immediately choose NeVa for this patient because to our experience in heart thrombus or thrombus which in patient which has a very long onset or late time in presenting, NeVa could be very efficient in removing out the thrombus. So in this patient also we used NeVa for 22 milliliters, and you can see that it has a white clot which is perfectly engaged, trapped inside the drop zones of NeVa. And these are all the thrombus that NeVa helped us pull out of MC1s and IC occlusions.
Can you come back? Previous slide, please. I don't know what Mark or Jordi thinks, but this picture shows how the NeVa is working. Because heart thrombus inside the stent. Inside the stent, that is because of the drop zones, so the thrombus coming inside the stent. Otherwise, with the others, you may not penetrate and pull back. This is the difference.
Yeah, exactly. Many times you find the clot inside. However, not always. Sometimes it can also be outside, but most of the times you feel that it works like it's supposed to.
And it has a closed tip. It may be the thrombus captured inside to hold it inside. So mainly what we are doing is closing the drop zones with the aspiration catheter. You have the advantage of the aspiration, and you have to squeeze you may have to squeeze the thrombus inside, then afterwards pull back all the stem out.
And did you see they are planning to have a version with a filter at the tip, right?
Yeah, they have a plan. I saw, but I didn't use it yet.
Yeah.
So if you are able to capture most of the clot inside the stent reaver, are you seeing less distal emboli after you withdraw the stent reaver? Seems like most of the clot is inside, and also has this cap that is like an umbrella.
Can you please go to the next slide, please? Show. These are the different thrombus that we captured out. As far as you go with the aspiration catheter, now the morphology of the thrombus has changed because you destroy the shape of the thrombus. But distal part is closed. It does not necessarily obviate the distal fragment. You may still see it. But if you look at our first pass TK2C and 3, that means we don't have that much distal fragment. I'm sorry, Arsida.
No, just in conclusion, with NeVa, high rates of first pass success and high rates of full recanalization can be achieved, and especially to our opinion, high rates of first pass success in ICA tip occlusion can be very good for NeVa stent retriever. Thank you, everyone.